This episode of the Great Girlfriends podcast is being brought to you by Daiichi Sankyo. For more information, visit healthywomen.org.
Welcome to the Great Girlfriends podcast, where we discuss life, love, laughter, and everything in between. I'm your host, Sibylla Muti, and
we are in for a treat. And I just want to really quickly thank our partners at Healthy Women for bringing us such fantastic experts to really help us navigate our health journey. We've learned so much in the area of women's health. And we've had amazing practitioners on to really give us some insights and wisdom and help us kind of decode and demystify our health. So this week, I'm back with another all-star, Dr. Sabrina Sahni. Hi, Dr. Sahni. How are you?
Good. How are you? Thank you so much for having me.
I'm so glad to have you. You have such an incredible bio. I read and I'm like, how does she do anything other than practice medicine? I'm not sure if it's if it's even possible. But you have such a long history, a rich history, and a really rich presence in medicine and women's health and reproductive biology. And so I'd love for you, Dr. Sahni, if you could jump right in and just give us a little glimpse into who you are, what you do, and why women's health is so important to you.
Sure. So I am family medicine trained by way of residency. So I went to medical school. I did, 3 years of family medicine residency. And in that time is really when my interest in, women's health and midlife women's care really kind of peaked. So, just early in my training, I started to see a lot of midlife women coming in with concerns of, menopausal issues, hormone therapy questions, breast cancer risk assessment questions. And I really started to see like a really large void in that area. So I kind of took it upon myself to do a little bit of research, and I found a couple of fellowships, and I went ahead and did 2 fellowships. So, because, one is never enough. So I did my first fellowship in specialized women's health, which really focuses on menopause and hormone therapy and, general midlife women's care. And then I did a second fellowship in medical breast, which really focuses on high-risk breast cancer patients, breast cancer genetics, and then breast cancer survivorship issues, which I think is huge and certainly an area that needs to be addressed more frequently. So I now practice in South Florida, and I love it, and I love all of my patients, and I'm really excited to be here and kind of share information with you all.
Good stuff. South Florida is a great place to be, especially in this winter where the rest of us are freezing and catching snow. So good for you.
I'm originally from Minnesota, so my heart is with everybody in the cold right now, but I'm enjoying it.
Oh my goodness. Yes, enjoy it. And you left off that you have co-authored several publications, and you've been acclaimed. You've been in a lot of acclaimed medical journals. So I think that's really important that you are able to speak to this issue, or this, not even say issue, but this health practice in a very specific way. And so I want to talk about, the journey. We go to the doctor knows everything, and we know nothing. We know what we feel, and we know what we are experiencing, but we don't know how to articulate it or how to make it mean something outside of pain or discomfort or looking for a solution. And so one of those big ones that comes up in high frequency with women is breast cancer, or even metastatic cancer, excuse me. And so I wanted to jump into a little conversation about that. A woman gets this diagnosis, or she gets introduced to this term, and, we go to the doctor. Most of us may not even jot notes or take video or, even audio to try to catch hold of all the things that are coming our way. But what exactly, when you get that first, you have metastatic cancer, what does that mean to a woman?
So metastatic cancer, and specifically, metastatic breast cancer, is essentially breast cancer that is spread to another part of the body. So, the primary cancer is in the breast tissue itself. Mm-hmm. And then for whatever reason, those tumor cells in the original cancer have broken off, and they've either invaded other organs, or they've, maybe traveled through the bloodstream or the lymphatic system to other areas. And so the most common areas that a breast cancer will, quote, kind of metastasize to or travel to would be the bone, brain, liver, or lungs. Okay. So at the time of diagnosis, if you're diagnosed with a metastatic breast cancer, really a metastatic cancer in general, it means that those tumor cells are now found in other places of the body than the actual primary tumor itself.
Mm, okay. Which feels like a 911 for me, right? So,
Right.
you know, that's a red flag for me. That for me would probably send me into a bit of a panic. And then there's the layers of prevention and detection that go into that. But I want to know about some of the differences that come along between those. I think there's HR positive cancers that have come up:
Yeah.
HER2 plus, HER2 negative, and
Yeah.
TNBC.
Right. So I always tell women there's really like four types of breast cancers in general. So there's something called triple negative cancer, which means there's no hormone receptors associated with it. And you had kind of alluded to this, that hormone receptors in general are receptors that can be found on breast cancer cells. And the
Mhm.
hormones that often bind to them are estrogen and progesterone. So if a cancer is considered hormone positive, it means that it has these receptors and that estrogen and progesterone likely fuels its growth. Okay. The
Mm,
HER2, which you also talked about, the HER2 positive and HER2 negative. Now, that's more of a growth promoting protein that can be found in breast cells. So either women
okay.
have really high levels of HER2, which would make it a HER2 positive cancer, or they
Mhm.
have low levels of HER2, which would make it a HER2 negative cancer. And this concept of hormone receptors and HER2 status is actually really important because it really does dictate our treatment. So you have that triple negative cancer, like I mentioned, which means that there's the hormone receptors are negative for estrogen and progesterone, and that HER2 is not expressed in that tissue. So that's your triple negative.
Mm,
Then you have the HER2 positive cancers. So HER2 positives, again, that cell protein that promotes growth. There are medications that are more targeted to the HER2 cancers. And then you have your HER2 negative cancers. And I kind of, divide those into two. So there's the HER2 negatives that maybe respond well to chemo, and the HER2 negative cancers that don't respond well to chemo. So that's
mm.
kind of where the four comes from. But like I mentioned, all of the hormone receptors and the status really is kind of the primary formula for determining how we treat and approach a lot of these cancer diagnoses.
Got you. So that's one of the things that I think great girlfriends you should take really strong note of is learning more about those hormone receptors because I think, like you're saying, that's a critical or need to know for women who are even having these conversations with their doctors. Correct?
Correct. And so, when I see women and, they may have just gotten a breast biopsy done that's indicative of cancer, oftentimes the report that the doctor gets is, you know, um, a specific type of cancer. So, say invasive ductal cancer. So, a breast cancer that arrives from the ductal cells in the breast. But those hormone receptors actually don't come back right away with that report. So, a lot of times when we give you this information, everybody's very quick to ask, what does that mean? What is the stage? What is the grade? What is all of this? And typically it takes about a day or two to really get those hormone receptors back from the pathologist to really
Mm.
understand what it means, right? And how we go about treating it. So yes, the hormone status and the HER2 status is incredibly important in terms of what your kind of course of treatment would be.
And are any of those impacted or affected by genetics or by food, or is that just how are those determined?
So they're not, interestingly, there's not really any kind of, food that would influence a certain hormone receptor or HER2 status. I mean, we do know that certain genetic mutations may be associated with certain hormone cancers. So, for
Hmm.
example, BRCA2 is a commonly known genetic mutation that can increase the risk for breast cancer. And we do know for whatever reason it has a higher propensity for that triple negative cancer. So,
Mm.
oftentimes, if you come to me and you're diagnosed with a triple negative cancer, chances are I probably would say, let's do some genetic testing and make sure that there's no, underlying genetic predisposition there.
Mm, okay. Okay. That's helpful to know. Hormone therapy and targeted therapies have come up a lot in conversation. And, I think women always want to know, like, what's best for me and how do you know? So, can you touch a little bit on targeted therapies and some of the new approaches that are now giving women just more optimism and more opportunity to live stronger through their
Yep.
diagnosis?
Absolutely. I mean, one thing I always say off the bat is there's two kinds of therapies. There's your local therapy, which is, more surgery and radiation that's, directed towards the breast itself. And then you have systemic therapies or therapies that kind of not attack, but, impact the whole body. So
Mm-hmm.
those are more of your chemotherapies or immunotherapies. And like you mentioned, there's so many different varieties of medications. There's always clinical trials going on for new medications to help treat breast cancer, specifically metastatic breast cancer, how to optimize, quality of life and how to, stop disease progression.
Mm-hmm.
But again, you're looking at probably a combination of, a variety of treatment options. So just to give you an example, because no two breast cancers are going to be the same and be treated the same, right? So if you have a hormone positive cancer, so your estrogen and progesterone are positive, and you have your HER2 is positive, chances are you're going to go towards a therapy that targets HER2, in addition to something that targets the hormone receptors themselves. So you're probably looking at a dual therapy, ones that affect both. Versus if you were, let's say, hormone negative but HER2 positive, your therapy would just be targeted towards the HER2, and you wouldn't necessarily need anything to target the hormone since they're negative, if that makes sense.
Mm-hmm.
There's other newer medications. So oftentimes when you do get diagnosed with the breast cancer, they'll often do certain biomarkers or look for specific genes that may be expressed in the tumors. And there's so many newer medications that are coming out that, can specifically target some of these genetic mutations in the tumor themselves. So separate from things like, your BRCA1 and BRCA2, but what kind of genetic mutations does the tumor have? There are PIK3CA inhibitors, there are PDL1 inhibitors. I mean, there's just really a large variety of different therapies to target different specific tumor characteristics of each breast cancer.
This brings me to a question. It's not really it's on our list, but it's not in terms of, we get a lot of our suggested approaches to medication and solutions from our friends. And you said something so powerful to say that no two are the same. And that, for you to really target a solution for your body, it has to be you have to have a specific approach that is unique to your body and what your needs are. So how important is it for us to, yes, share these conversations with our friends, but also really redirect our friends back to their doctor to ensure, because you'll hear from one friend, well, I had this, and this is what my friend had in stage 1, stage 2. And, so then people go back and they ask these questions that are based off of their friends' experiences and wanting to know, was this available to me, et cetera.
No, absolutely. I think that kind of goes, from a complete medical standpoint. I mean, no two diseases in general are probably going to be treated the same. It's always going to be individualized and dependent on the person. And, it's good to be aware of different regimens. So I actually like that and talk to their friends if they share these similar experiences to learn, right, to feel empowered that this is something that worked for me, this is something that didn't work for me. And I think it's a good way to bring these kinds of conversations up with your doctor, so you can even remain informed of what's out there too, right? So maybe it doesn't necessarily apply to you in and of itself, but you can maybe understand a friend's diagnosis better, or how that medication might help somebody else that could be affected in that way, if that makes sense.
Yeah, definitely makes sense. Let's talk about the importance that we really, really, I guess when you receive a diagnosis, that you understand the spectrum of the disease, early to late stage, so you can kind of know where things fall into play. What is it that how can you teach someone the spectrum, or how can you help them understand where they sit? And because, I think when we hear cancer, we may not assume that it's a death sentence as we used to in the past, but it is, the fear kicks in and the concern of, what next and how do we do this? How do we manage?
Right. So, there are a variety of different stages, right? So there's stage 0, there's precancerous stages, stage 0, all the way up to stage 4, which is what we consider to be metastatic breast cancer. And oftentimes, when it comes to metastatic cancer, you can, about 6% of cases, I believe, are what we call de novo metastatic breast cancer, meaning at the time you're initially diagnosed, you're diagnosed with a stage 4 off the bat.
Mm.
But it's also important to remember that you can be diagnosed with the breast cancer much earlier, right? So you can be diagnosed and you can have a stage 0 breast cancer, which is going to be different than a stage 2 versus a stage 3. And it's really, like you said, a full spectrum.
Hmm.
I think it's also important to know that, a woman could be diagnosed with breast cancer very early and then go on to have kind of that metastatic component later on in life,
Mm.
after she's been treated with, her local and systemic therapies.
Hmm.
So I think, the increased screening and the surveillance is really important. But I think, the best way to talk to patients is really just to be honest and open and educate them to feel empowered to know what decision will be best for their body, right?
Hmm. Hmm. So true, because I think with that, you give people access to information, they can make more informed decisions. And that's really what this health journey is about, being able to have the knowledge to make informed decisions and to feel equipped to do what's in the best interest for your quality of life.
Right,
I really think
absolutely.
that's where great practitioners come in to play and help support that, knowing that that's the intention on both sides. I would love to know what some of your learnings have been in terms of racial disparity and disproportionate impacts of breast cancer on communities of color. What have you seen? What does the data show us? What are we learning, and what's new, or what's knowledgeable rather?
Right. So this is an ever-growing topic, certainly. I mean, I think we know off the bat that white women are more likely to be diagnosed with breast cancer. Native American, Indian women have the lowest rates of breast cancer, and so when we think of
Mm.
survival, those racial groups kind of shift. So actually, Asian women, specifically Chinese and Japanese women, actually have the highest breast cancer survival. But unfortunately, Black women, on the other hand, are more often to have tumors that are associated with a much poorer prognosis. And kind of how we talked about that triple negative breast cancer earlier, Black women have a higher rate of that triple negative breast cancer. And unfortunately, it is associated with a much poorer prognosis. Regardless of race, I think the data really shows that socioeconomic status has a huge role in just health disparities in general. So
Mhm.
lower socioeconomic statuses can be associated with higher rates of breast cancer. They can often present at later stages. They may be inadequately treated, and that's really regardless of what race they are. So that, I think, is a bigger, impact factor. And then I think, honestly, my take home message would be the comorbidities, right? So I think things like hypertension and especially obesity, which I think is just, probably one of the biggest epidemics that we have right now, really have high links with regards to the breast cancer. So regardless of race, I think obesity and low physical activity and how we're nourishing and fueling our bodies has a dramatic impact on not only cancer risk, but overall chronic disease risk. So that's something that I'm really passionate about, and I always counsel my patients on is, to have a good, healthy lifestyle and to remain active and to limit alcohol and to really be really vigilant about your health, right? So I want my patients to feel empowered and, to be their own health advocate and to make sure that you don't miss that mammogram, to make sure you don't miss that doctor's appointment, and if you feel something, you notice something, to really speak up about it. No question is dumb. I have so many women saying, I felt silly coming in today, and I wish women would stop saying that, because if
Mm.
something feels off to you, you should really go to your doctor and advocate
Mhm.
for yourself and speak up about it.
So true. Yeah, because doctor, they're in place to support your wellness. They're in place to support, ensuring that you can have, again, the happy, healthy life that we all want to have. Um, I'm curious to know if you saw increase in mortality rates related to cancer during COVID. Maybe lack of access to healthcare, any of those things.
So I think long-term data might be able to show that. Just in my own personal practice, honestly, I think I'm still going back and calling patients now and saying, you missed your mammogram, and I understand that, COVID is, um, was happening and things may not have been as accessible, but we should never kind of forget some of those preventative things that we need to take care of our health too. I saw, not even from a cancer mortality standpoint, but I certainly saw increase in cardiovascular events because of COVID, just by virtue of people being terrified to go to the emergency room.
Mm-hmm.
So I think it's important that we're all in this. We all have safety precautions in place. I think it's so important to still go to your doctor. And I think there is value in telehealth, which may or may not be some sort of a silver lining here, because I think that there's certainly a role for it. But there are ways to get in contact with your doctor, and your doctor is never too busy. And that is what we're here for. So
Mm-hmm.
I would say keep don't let your health kind of take the backseat in light of this pandemic, because really it's the most important thing.
For sure, for sure. I mean, more so, I guess now than ever, we're understanding that we can't take any symptoms lightly in our body, and that we need to be, really great stewards and attentive to our bodies and what our bodies are saying to us. Um, and I think everyone's, been on heightened alert, through COVID. And I think COVID has also reminded us that we have to prioritize our health. Everyone's now looking for do it yourself, stay at home solutions to really support, some of the questions that we're asking without having to go into practitioners. But I think there's a point in your journey for sure where you have to call on a professional to really guide you and give you the insights that you need. And that mammogram specifically has been a lifesaver for so many women. And I hear that's one of the top forms of preventative care. What are some of the other things that you think are high level preventative care solutions that women can take home?
Yeah, absolutely. So early screening, like you mentioned, is by far and away, the most important thing. So mammograms really should start at age 40 and should happen annually thereafter. If you have, a strong family history of breast cancer, or you've had, abnormal biopsies in the past that may be associated with an increased cancer risk, certainly talk to your doctor about understanding what your specific breast cancer risk is. Because if you are found to be at an elevated risk, there are certain, surveillance mechanisms that can be implemented for you so that you get more enhanced screening. So I think that's important in understanding your risk. I make it a point to actually go over the mammogram with my patients. So I
Mm-hmm.
talk about things like their breast density. So breast density, we know, can be a risk factor in and of itself for breast cancer. So
Mm-hmm.
understanding that and understanding how certain maybe hormones may play a role in how that breast density might change. And then obviously things that all women can do. So like I said, obesity is a huge factor in terms of breast cancer risk. So maintaining a healthy lifestyle, staying as active as possible. I know it's COVID and everybody's kind of, everybody jokes about the quarantine 15, but I'm really rooting for my patients to be as active as possible, and to utilize a lot of these at home exercises, or to take extra steps, or to not lose sight of those things, because even from a physical fitness standpoint and even a mental health standpoint, I think it's so important.
Yeah.
We also know that alcohol can increase breast cancer risk as well. So I always tell women really to limit that. Guidelines typically say under 7 drinks per week, but I tell people to kind of do it closer to less than 3 drinks a week,
Mm.
to just maintain good breast health.
So good, so good, so good. So, and I'm just curious to know from, all the research and the work that you do, what do you want to be your legacy in medicine?
Oh gosh. This is a good question. I mean, I think I want to be remembered for helping women. I mean, I think
Hmm.
the whole menopause transition and the changes that occur at midlife are really, really hard. And
Hmm.
I think I've seen it with my own mom. I've seen it with patients, and a lot of women during this time feel like they're alone, or that this is just something that they deal with. And
Hmm.
I think that there's a it's commonly associated with the really negative connotation of it's the end of one's youth, but really it should be something that I think should be celebrated, because it's really
Hmm.
a new chapter and new beginnings. And I just want to be remembered for advocating for women, helping women through this transition, and doing good. I don't.
That's
for,
good stuff.
yeah,
Yeah. I mean, the best of us will be, remembered for the good we do, right? And the reward of the good we do and how it affected other lives. So I think that would be remarkable. And I think you're on the right track. And I want to thank you so much for sharing all of your wisdom with us today and your insights and making it super practical for us to learn and simplify some of the conversations we have with our practitioners. Where can our great girlfriends reach out to you or connect with you on social media or follow your work?
sure. So I am on Instagram at SKS_MD, and I'm on Twitter at Sabrina Sahni. So you can feel free to follow me there. And then I just want to applaud you for having resources like this podcast to help women and give women, a nice outlet to learn about their health and their bodies. So I applaud you for all that you're doing. And I'm so honored to have been a part of today's podcast. So thank you.
Great girlfriends, did you enjoy this week's episode of the podcast? If so, would you please give us your amazing review on iTunes? Every single review helps another great girlfriend get plugged into the podcast, into the community. Speaking of community, make sure you join our Facebook group, The Great Girlfriends. You follow us on Instagram at The Great Girlfriends and on Twitter at _great GFS. Last but not least, we'd like to thank my amazing husband, Kwaku, Sam and Dilly, and all of you for being a part of the global community that makes us so strong. Please remember to share with your friends. Keep listening and keep being a great girlfriend. I'm Sibylla Muti, and I'm out. Peace.